going to move on with our cases without delay, and we move straight on to Olivia, going from moderately complex to a bit more complex. Over to Olivia for your case.
Hello, everyone. It's great to be joining this wonderful panel again. I'll be presenting a 22-year-old of African descent in her first continuing pregnancy. She didn't have any past medical history nor family history of note, but was of slightly high or overweight BMI. There was minimal antenatal attendance, which posed significant challenge in the management of this pregnancy. Indeed, this patient only saw her GP up until 24 weeks, and her first engagement with women's services was at 25 weeks. She was self-referred, brought in by her mother to me at 25 plus 4 weeks, and the only history given was a concern with the fetal cardiac anatomy. Looking through the fetus transversely, and you can see this with these video clips, going through the four-chamber cardiac view, it's quite apparent that there's a large cardiac tumor involving the left ventricle, a few smaller ones involving the right ventricle, cardiomegaly and some distortion to the fetal cardiac anatomy. But you can appreciate that the outflow tracts do appear patent, and using a color Doppler, you can see that there is some restriction to the filling of the left ventricle through the mitral valve. And you can see this again here with these cardiac settings looking transversely through the four-chamber view. So moving on to the next. This is looking at the fetus sagittally. And as you can see, the image quality is a bit challenged by the anterior placenta and the slightly high BMI, but you can see this very large cardiac tumor involving the left ventricle posteriorly. So these masses in the left ventricle were about 27 millimeters, and the ones on the right were about 8 millimeters at the time. There wasn't any high drops. This patient agreed to a fetal echo with one of my pediatric cardiologist colleagues, where the multiple cardiac tumors were also reported, a poorly filling left ventricular cavity, functional mitral and tricuspid valves. There was mitral regurgitation, prograde flow through the aortic and pulmonary valves without stenosis nor regurgitation, and there was no outflow tract obstruction. My assessment of the rest of the fetus did not demonstrate any apparent brain or other extracardiac tumors, and in fact, the rest of the fetal anatomy and fetal growth appeared normal. There were limitations to advanced neurosonography posed by a persistent breech position, which did not allow transvaginal assessment, the BMI as well, and anterior placenta. My counseling detailed the likely differential diagnosis, and I explained that in the majority of cases, cardiac tumors are rhabdomyomas. A likely underlying cause, I explained that needed investigation was tuberous sclerosis. Even though there weren't any other extracardiac tumors, the multiplicity of them made this something important, and also the fact that brain tumors tend to appear later in gestation. I did emphasize the need for MDT involvement and investigation. Very pleased that she did attend a fetal echo with a cardiologist, but this patient declined referral to a clinical geneticist, but I was able to explain that even without a family history, this could and often does occur de novo, and I offered an amniocentesis to try and rule out tuberous sclerosis. The need to continue monitoring the fetal brain was emphasized. The plan discussion detailed follow-up, ongoing counseling, and plans around delivery. For follow-up, I planned for 4 weekly assessments to assess for the development of any brain tumors, as this would implicate tuberous sclerosis further, as well as the degree and severity of the associated clinical manifestations, which I explained could be a combination of seizures, neurodevelopmental, cognitive, or behavioral impairment. I explained we needed to continue looking at the heart, as although rhabdomyomas tend to resolve spontaneously, these were very large ones, and we needed to look out for hydrops, arrhythmia, and outflow tract obstruction. This patient did require ongoing counseling. With regard to an amniocentesis, I explained that prenatal tuberous sclerosis testing wasn't available in South Africa, but would require local DNA extraction and testing abroad with a further 14-day turnaround time and a cost of up to 31,000 rands. At this point, the patient and her partner had explained that they would not consider termination of pregnancy, regardless of any underlying diagnosis nor prognosis. And we explained, or I explained, that delivery would need to be in a tertiary unit with cardiac intensive care facilities. Unfortunately, this patient did attend further fetal specialist follow-up, no cardiology follow-up, and only had or attended 2 further obstetric assessments at 30 and 35 weeks, where the obstetrician reported no apparent brain lesions. She attended delivery by cesarean section electively, where a 3.1 kilogram female was delivered at 37 plus 4 weeks. And a postnatal chest X-ray demonstrated a very, very large heart. A postnatal echo clearly demonstrated this very, very large rhabdomyoma impinging on the left ventricle and a poorly filling left ventricular cavity. You can see with this video clip, in addition, a large PFO of 5.5 centimeters. Both mitral and tricuspid regurgitation was reported. There was a large PDA of 4.5 centimeters bidirectional flow and balanced pressures, retrograde diastolic flow through the descending aorta. There was no coarctation nor outflow tract obstruction reported, but you can see how poorly the left ventricle was functioning. And that's also demonstrable on color Doppler and with these video clips, very, very poorly filling left ventricle. CT angiogram postnatally clearly demonstrated these masses, which you can see in these images here. And the left ventricular cardiac rhabdomyoma was reported to measure about 34 millimeters postnatally, and the ones on the right up to 14 millimeters. The CT angiogram postnatally documented a 6.7 millimeter large PDA, an outflow, pulmonary outflow of 6.7 millimeters. Pulmonary arteries were reported to be narrow. There was also narrowing of the aortic root and displacement of the right ventricular outflow tract to the right, and a large ASD of 11.3 millimeters. Postnatal cranial ultrasound, and this was supported by postnatal MRI, reported bilateral subependymal giant cell astrocytomas at foramen Monro, scattered white matter lesions, a left posterior cortical tuber, slight right retinal nodular thickening. CT of the brain postnatally, there seemed to be an apparent small hemorrhage in the area associated with the frontal horn of the right ventricle. There was extensive postnatal counseling on the cardiac intensive care unit, detailing the poorly functional left ventricle, the multiple intracardiac tumors, the extracardiac brain lesions suggestive of tuberous sclerosis, and all pointing to a poor prognosis and poor candidacy for surgery, such as a Norwood procedure. So a plan was made to stop Prostin and observe. The baby deteriorated metabolically and hemodynamically on day 9. Off Prostin, the PDA remained open, and the baby succumbed to a late neonatal death. An autopsy was not performed at the parents' discretion, but they agreed to genetic testing on an EDTA blood sample, where next generation sequencing indeed identified a pathogenic variant involving the TSC2 gene. And a final diagnosis of tuberous sclerosis was made. As the parents weren't affected, it was explained again that this was likely de novo with a low risk of recurrence for future siblings, albeit slightly higher than the general population. In conclusion, making the diagnosis of tuberous sclerosis prenatally is challenging, especially before the appearance of brain lesions. Advanced neurosonography versus MRI. I think this depends on the setting and circumstances. Certainly a persistent breech presentation, highish BMI and anterior placenta might point to MRI as being of more added value. Counseling can be difficult. And for the cardiologists, I'm curious to know what treatment options you consider for giant rhabdomyomas, whether surgery or treatment with mTOR inhibitors such as sirolimus. Thank you very, very much.